Welcome everyone. Today we're diving into one of the most crucial topics in maternal fetal medicine, first trimester aneuploidy screening, sonographic and biochemical approaches. Now, why does this matter? Because the first trimester is not just the beginning of pregnancy, it's the window where we can pick up life-changing information. With the right tools, we can detect chromosomal abnormalities early, guide families with accurate counseling, and improve outcomes for both the mother and the baby. Think of it as reading the pregnancy's roadmap before the journey really begins. And in this lecture, we will explore how ultrasound and biochemistry combine to give us that map. To the details, let's see our objectives for today. By the end of the session, you should be able to first understand the role of key sonographic markers, nuchal translucency, the nasal bone, and the ductus venosus Doppler in aneuploidy screening. These aren't just measurements, they are powerful early indicators that can change the whole course of pregnancy care. Second, we will explore how ultrasound findings integrate with serum markers because when imaging and biochemistry speak the same language, our screening becomes far more accurate. And finally, we will review the role of non-invasive prenatal testing or NIPT in modern screening programs. This is a game changer in how we approach risk assessment. So by the time we're done, you'll see how these elements connect into a comprehensive first trimester screening strategy. Let's start with the basics. What is aneuploidy? Uh, Aneuploidy simply means an abnormal number of chromosomes, and in prenatal medicine, the most common examples we focus on are trisomy 21, 18, and 13, conditions that have profound implications for both the baby and the family. Now, why do we screen for these conditions in the first trimester? The purpose of screening is not just to provide a definitive diagnosis, but to identify pregnancies at high risk. By doing this early, we open the door for families to make informed decisions and for clinicians to plan the right follow-up investigations or management. In other words, screening is our filter. It helps us recognize which pregnancies might need further attention long before symptoms or complications appear. With that foundation in mind, let's move to the cornerstone of the first trimester sonographic screening, the nuchal translucency method. Let's begin with the most iconic marker of the first trimester screening, the NT. By definition, NT is the fluid-filled space at the back of the fetal neck, measured between 11 weeks and 13 weeks plus 6 days of gestation. By timing alone isn't enough, we also need the ground rub length in the correct range, around 45 to 84 millimeters. Now the technique matters. We measure it in the true mid-sagittal plane of the fetus, placing the calipers on the inner border of the translucency space. Accuracy here is critical because a few tenth of millimeters can shift the risk calculation dramatically. Clinically, which is why is this important? Because an increased NT is strongly associated with trisomy 21, 18, 13, and even other genetic or structural conditions. In fact, NT is often the very first clue that something may be different about this pregnancy. Translucency, it all begins with one critical skill: getting the perfect mid-sagittal view of the fetal face. So how do we know we have nailed it? There are four check points to confirm. Anteriorly, look for the echogenic tip of the nose and the rectangular shape of the palate. These landmarks tell you that you are truly in the mid line. Centrally, you should see in the brain the translucent dicephalon, a reassuring sign that your section is correct, and posteriorly the nuchal membrane should be clearly obtained. Only when all these elements are present we can say we have achieved an optimal mid-sagittal view. Anything less and the NT measurement becomes unreliable.